We shall now go on to our next speaker, Dr. SORABH BHARGAVA, who's a consultant eye phaco surgeon from BHARGAVA Eye Center, Rajasthan. And he has another interesting video for us to see. So do stay with us, Dr. Sharad.
Thank you so much. Good afternoon, ladies and gentlemen. Thank you, AIOS, ARC, and especially Dr. Chitra for the opportunity to speak on this podium. I'm going to talk about the top pearls in preventing a PCR in polar cataract surgery. Now, this was the case of polar cataract I operated 2 months back. And despite all precautions like good rhexis, mechanical hydro-free dissection, slow motion phaco, visco exchange during all steps of surgery, this was the outcome. Here, a hydrophobic implant, which though did not open slowly and would not have caused any damage during routine surgery, caused this. A large triangular PC rent was staring at me, which made me rethink my surgical strategies. I realized that a case of posterior polar cataract is never over till the surgery is actually over. So here again is a case of polar cataract, which I operated recently. And here I was determined to prevent an unfriendly surprise by doing a meticulous surgery, the top pearls of which are as follows. One should do a thorough preoperative evaluation and differentiate between a localized posterior subcapsular cataract and a polar cataract. The rhexis, in this case, I'm aiming for a 5 millimeter rhexis. Getting a perfectly sized rhexis is extremely critical in such cases, since we may need to take help of the rhexis to achieve an optic capture in the event of a PC rent. As we all know, hydrodissection is contraindicated in such cases. Here I'm doing a hydro-free mechanical dissection to free the attachment of the anterior cortex with the capsule. This I achieve using a blunt iris spatula. Now, polar cataract surgery is essentially a low flow, low pressure surgery. As you can see, the IOP is only 34 millimeters of mercury, which works out to be a bottle height of 54 centimeters. The average AFR is 30 and the average vacuum is just 350. It's a soft cataract and I'm working to emulsify the nucleus from the periphery towards the center. The key to success in polar cataract surgery is to do a visco exchange to maintain the IOP in the safe range during every step of surgery. So here, before I exit the phaco probe, I'm pressurizing the eye, just adequately pressurizing the eye, not over pressurizing, to maintain the IOP. A bimanual irrigation aspiration provides good access to 360 degrees of the capsular bag, so it's very helpful. And here again, I'm using the visco exchange technique. Now comes the final step, which is the implantation of the IOL. And from my past experience, I now prefer the use of a single piece hydrophobic implant, which unfolds very gently into the capsular bag. If such an IOL is not being used, I would advocate the use of a cohesive viscoelastic to cushion the fragile posterior capsule in such cases. So my final learning from polar cataract surgery is that we should never allow the anterior chamber to suddenly deepen or get shallow. We have to slow down each step of our surgery, and for that, patience is a great virtue to have in such cases. Thank you for your kind attention.
Thank you very much, Dr. Bhargav. That was again another wonderful video and lot of learning tips. And as I go on to the expert panel, I have the first question to ask is, hydrodelineation you have not done in your cases. You've started off with a mechanical delineation alone. Now, does a mechanical delineation rule out a hydrodelamination, need of a hydrodelamination procedure? And how do you explain that a mechanical can take the role of a hydrodelamination?
Very correct, ma'am. Actually, if you notice, this case was a very soft cataract. He was a young patient, about 30, 32 years old. Here, I did the mechanical hydrodissection, and I did not require the need for a delineation, like an inside-out delineation as advocated by Dr. Vasavada, because the nucleus parts were coming on very well from the periphery to the center. Had I faced certain difficulty, then I could have gone for a visco delamination or a hydro delineation.
A mechanical delamination, not a mechanical hydrodissection. You didn't do a hydrodissection. You just
no. I didn't do a hydrodissection at all.
But don't your others on the expert panel? I want your thoughts. Don't you think by doing a hydro delamination, you're creating multiple layers of cushions, which is actually protecting the posterior capsule? A mechanical separation is very much on the superficial plane. So, Dr. Gaurav, would you want to add? Hello, welcome to the meeting.
Hello, ma'am. Thank you so much for inviting me, and hello, everybody. Very nicely shown. I just thought of two things. In fact, your point is absolutely right. For myself, I prefer to do a little bit of hydrodelineation and have a golden ring kind of a thing, so that you have then that scaffold on. Yeah, hydrodelamination, not delineation, so that you have a scaffold, of epinuclear, tissue. I mean, some cortex or something which will stay till the end, and then you gently kind of remove it from the equator and leave that last chunk right in the middle for to be kind of floated out in the end, not even aspirated. So I totally agree. And two more quick points which I thought I can add here. One was that you did mention that you would like to have a perfect 5mm rhexis, but you did not use any device to guide you. I mean, I would have used a rhexis marker, which is at 5mm to ensure that I get a 5mm rhexis.
Sir, I did use a device, but it's a 4-minute video, so I couldn't show every part of the thing.
Sure.
I did use the BHARGAVA rhexis marker.
Sure. And the last point is that even hydrophobic IOLs, which because they have a very, the haptic, the way it folds, if you touch while injecting, if you touch it, so you have to have a deep AC, relatively deep AC with viscoelastic. I have broken posterior polar cataracts when my haptic tip, like the bent part, touched or rubbed against that posterior capsule. So you have to ensure that you go and inject it in such a way that it doesn't touch the PC at all, and it goes under the rhexis and in the periphery and then opens up. If you, in fact, hydrophobic can cause more problems because the haptics, as far as how sharp they are or how rigid they are, they can actually puncture the posterior capsule in that central area if you touch that area. These are just 2-3 things that I thought.
The other question which I have to ask is, he had a PCR when that single piece IOL was there in the bag in the first case when a good surgery was done. Now, I want thoughts like why would any of us would you place a single piece haptics in the sulcus and try to do a reverse optic capture? Would you do it, or would you remove the lens and place another 3-piece multifocal lens in place? Dr. Mohan, Dr. Ramurthy, your thoughts?
Yeah, we can do a reverse optic capture. That's one thing, but a little difficult, but we have done it. If the first case, because the second case, I was not able to see some problem with my Wi-Fi. First case, I think he did wound-assisted implantation. I think we should avoid wound-assisted implantation in posterior polar cataracts, and also the push type of injectors, because these are injectors which you don't have any control. And even if you touch, as Gaurav was rightly telling, even if one haptic touches the PC is already very fragile and it can open up. So once you have a PCR there and you have a single piece lens there, you can do a reverse optic capture. And if they have sufficiently good, posterior capsule, you can do a lens in the bag itself. So reverse optic capture is possible, definitely.
I think reverse optic capture, by definition, is where the haptics is in the bag and the optic edge is in the sulcus. Yes. But in this situation, if there is a fairly large rent which has been inadvertently created, leaving the haptics behind there might be a little difficult. So what could be done is more a conventional optic capture where you bring in the haptics into the sulcus, and then because he has a nice 5mm rhexis, push in the edge of the optics inside. I mean, leaving the haptics inside and creating a reverse optic capture may not stabilize the lens too well. But then whether you leave the haptics or optics in the sulcus, the question always arises as to whether this is going to cause inflammation, raise in pressure, etc. So, but all of us have done it once in a while, though it's not the best way to go. And one other just point I want to add is that very often we talk about, of course, none of us do hydrodissection. It's basically hydro delamination. But once the bulk of the nucleus has been taken out or the endonucleus is taken out, I'm not wary of going in with a visco dissection or even a hydrodissection, because no longer the bag is under stretch. And to delineate the peripheral cortex or the epinucleus, it's a good idea to do a little bit of hydrodissection so that you can remove that more easily.
I could even do a visco dissection, but I still want to leave a message that leaving a haptics in the sulcus, a bulky haptics of a single piece, is definitely not the way to go. It is quite acceptable to remove the entire lens and place a 3-piece multifocal. But when we are talking of multifocal, supposing at that point of time you don't have a 3-piece multifocal with you, and you have placed a single piece, or rather in a different kind of a situation where you have placed a single piece in the bag, and you decide, the patient comes back to you later for want of a multifocal IOL, would any of you suggest placing a multifocal piggy bag in these patients? And if so, how would your calculation be if the patient has a great distant visual acuity, plano for distance? Anybody?
Yeah,
I think
we can put a multifocal lens, piggyback lens in the sulcus.
Yes,
Yeah.
so then how would you make your calculation for these eyes if primarily a single piece IOL was placed in the bag and later the patient still insists on a multifocal IOL?
We have the plano +3 lens.
Plano plus 3.
Yeah, plano +3 lens which you use.
Yes.
And it's pretty good actually. It works wonderfully well. Rayner multiflex, that's what I have got experience with.
We also have the.
I just want to add one thing, Chitra, that nowadays I do posterior polar cataract 100% only femtocatalysts. So even if the patient cannot pay, because we've got better control, I'm able to have intraoperative better control. I'm able to keep the offset 900 microns. And of course, I do a very limited hydrodelineation as well.
Dr. Ajay, did you notice?
Here?
Yes.
Yeah. So Dr. Saurabh, very well done and very nicely presented. I just wanted to add one point that routinely now we practice pre-operative OCTs. So we perform pre-operative OCT evaluation because that gives a fair idea whether the PC is intact or is there any breach. So as Dr. Mohan rightly pointed, I think femtocataract is the way to go. And this also pre-operative OCT evaluation gives us a fair idea whether there is any discontinuity or there is a pre-existing break in the PCs.
And moreover, the morphology of a polar cataract is that it has a pyramidal architecture which extends into the anterior cortex. So you can differentiate a classical polar cataract from, and plus the signs like an onion skin and all that things now. So you can differentiate it from a posterior subcapsular cataract.
Can I make a small comment?
Yes, Anaga.
In this case, the rhexis was perfect, the surgery was perfect. So it was only in the last stage of the IOL implantation that he had a problem.
Yes.
So this problem can occur even in a patient of flax. So point here is, I think the take-home message was when it opened up suddenly and jerkily. So many times these injectors are repeatedly used. So we need to be very wary about how these injectors are cleaned. And at the same time, maybe we have to be extra careful in posterior polar cataracts when we are injecting these lenses. Be very gentle, because we should not use the same amount of pressure as we would, especially if it's a high diopter lens. Number one. Number two is, in such cases, if we are not very sure, maybe you can inject it on top of the iris first and then put it down, gently rotate it instead of directly directing it towards the posterior capsule. So that may have saved the day, because flax or no flax, I think this can happen even in a flax case.
That's a very valid point, actually.
Yeah.
And this is the take-home message that I have taken, that you should not try wound-assisted. You should not try to use lenses which unfold in a jerky method. So that is the take-home message that I've learned. Otherwise, all things are written in our texts, but this is the extra point that I noted.
But
even the push types injector, no, push type, don't use the push type.
Yes.
The push type, if you use a screw type injector, maybe the delivery, the lens would be more controlled.
Yes.
Controlled.
Last question I have, Dr. Ajay, you saw his video. In the sub-incisional, the nucleus fragment which were there, he has not done a hydrodelamination. He's just done a mechanical delamination. How would you get approach when the nucleus is stuck there how do you get approached to remove the sub-incision? She says, no, he removes the periphery and then comes to the center. How do you avoid that challenging moment?
With a side port spatula, I would mechanically get that part as much as close to the central part and then take it. I mean, that's a challenge when you in a soft where you don't want to rotate it. And how do you do it? So normally, or either that or a visco. Go from the side port, put visco, and just get it the center and do. At the same time, always be ready that don't overinflate. I mean, this is something that we are saying, that inflate the bag just enough. Even when putting that lens, just enough, because there have been, as we have said, even the last case where you put the lens and you try to hydrate the wound and the PCS rupture. That is also happening. So this is the right balance one is to maintain right to the end of this surgery. As he said, the surgery doesn't end till it ends. So that's it.
Yes. And Dr. SORABH, that was a wonderful,
wonderful.